We just want attendees to join
in.
Hey, Kevin, I think you went off presentation mode there.
I know, I'm looking for my view that shows attendees. Oh, we got 82 on, okay. Good morning, everybody. We'll give it another minute here. It's not quite 9 a.m. All right, we'll get going. We got quite a few attendees that have joined. I'm Kevin Polari, and I lead our Kentucky practice for Deloitte Consulting. And we're proud to be the sponsor for the eHealth Summit and partner with HIE. Just a few quick points about Deloitte. We've been a presence in Kentucky for over 50 years. We have 2 offices, Louisville and Frankfort. One of the many examples of our commitment to Kentucky, we hired 57 students in the past year from 7 different campuses. Our government consulting practice spans several cabinets, but we view the Cabinet for Health and Family Services as sort of the preeminent focus, if you will, as it impacts the health and healthcare and lives of Kentucky citizens. And a great example of that is the work we did on COVID, building the contact tracing system, supporting the vaccine management rollout. And really, I think a key point here is that Kentucky has many best-in-class solutions that really are leaders across the country. And maybe the best example, and certainly the most appropriate example today, is HIE. It really is a best-in-class solution across the country. We're excited about many of the features that will be discussed today. It's been very pivotal in supporting the health and increasingly so the health of Kentuckians. A great example is the pivotal role HIE played in the response to COVID and the ability to acquire test results and communicate data across to the various systems. So, we're excited about the conference today. We're proud to support CHFS and HIE and excited about the future capabilities you'll hear more about today. And with that, I want to introduce our keynote speaker, Dr. Alicia Farlisi. She's a doctorate of nursing practice in informatics, a retired captain, level 06, and a previous senior leader, really with an illustrious career at the U.S. Department of Health. Dr. Farlisi worked on national health IT policy and programs and in contributing to many health IT regulations such as the 21st Century Cures Act. She'll provide insight today on the state of HIT from a national perspective, and we're excited to have her. So with that, I'll turn it over to Dr. Farlisi.
Good afternoon or good morning. I'm getting my screen share going so I can display my screen. Do I have hopefully I have the one up without my notes. Can somebody give me a thumb up if you're seeing the right screen since I'm on too? All righty. So happy to be here today. Happy to be back in Kentucky. What wasn't mentioned is I'm back in Kentucky after being gone for 26 years in the military. I retired last September and just relocated back to Lexington. So really excited to be back here, back home. It sure has changed quite a bit since I left 26 years ago. And here, being able to speak with all of you guys about my previous work and what's going on at the federal level with respect to health IT and the impact that it could have on Kentucky citizens. So It's early in the morning and federal policy is not the most captivating topic for a first morning discussion, but I will try to keep you interested, and I've got some really dense slides that I will gloss over, but they're really meant there as a resource for you, and I am as well a resource for you. And so I provided my contact information at the end of this presentation. But the activities from the recent legislative and regulatory efforts are definitely changing the health IT landscape, and most importantly, the health experience for individuals and those privileged enough to help them along their journey. And that is all of you as well.
Dr. Farley, good morning. Sorry to bother you. This is, we are seeing your page with your notes. If you want to maybe swap.
Okay, I will swap my displays.
Sorry to interrupt you. There we go.
No worries. Is that good?
That's
okay.
Perfect. Thank you.
So, as I mean, although many of us here on this panel in this conference today might not be in a direct care role, I'm quite sure you all have felt a renewed purpose and sense of service, knowing that the work that you're doing, as Kevin just mentioned, is really helping with capturing and sharing the critical data that's necessary for the response during this pandemic, to address community needs, and to support routine healthcare delivery, which still goes on despite all that's going on with COVID. And I know it's hard at times to see how the policy and programmatic and technical work that you do touches individuals and impacts their lives, but it does, and our work is essential. So I'm pleased to be here today to share a little bit more about those federal efforts, and hope throughout the conference today you'll see the parallels to the work that you're doing now. A brief overview of the topics I'll discuss today, some key health IT milestones and the responsible agencies for those, a brief overview of the 21st Century Cures Act, which was from 2016, and then the rules that followed from that from both the Office of the National Coordinator for Health IT and the Centers for Medicare and Medicaid Services. We'll briefly go over the final rules for HIPAA and Stark anti-kickback, and then touch on a few special topics with respect to telehealth, substance use disorder, and social determinants of health. So key health IT milestones. It goes way back to HIPAA, and most will argue now that the information blocking components of the 21st Century Cures Act is kind of our next HIPAA. So we had HIPAA, and then the Consolidated Health Informatics Initiative was really the federal government's first foray into evaluating and adopting interoperability standards and requiring them for use at that time just in federal programs. And I had the privilege of running that program, and that's kind of how I ended up in informatics from clinical nursing. Then CMS launched the Doctor's Office Quality Information Technology Project, which many may be aware of. And DOCIT was really the first time that the government was supporting, like pre-meaningful use, supporting the adoption of electronic health records in doctors' offices, facilitating their transition from paper to electronic, and assisting them with collecting the data and submitting it to the CMS for quality improvement projects. In 2004, ONC, the Office of the National Coordinator for Health IT, was actually established by a presidential order. And that's at the time where I joined ONC. And they issued the first contract to the Certification Commission for Health IT. And that was the first voluntary, nationally recognized voluntary certification EHR program. And it's important to know, although it may not feel like it, the current certification program is also voluntary. But you know, we know that most of the market is certified because there are financial incentives to do so, but it is a voluntary program still. In 2009, the American Recovery and Reinvestment Act and the HITECH Act as a part of it infused a lot of energy and authorities into the health IT space at the federal level, $19 billion for health IT interoperability efforts. That was the launch then of the formalization of the ONC office. Rather than being by executive order, it was now instantiated. And it was the beginning of the first rules for certification, the first being the 2011 edition, and the beginning of the Meaningful Use Program. There have been several editions of certification, as you probably are aware, but all are since retired. And the only active certification edition at this time is the 2015 edition. The Medicare, sorry, I was making sure my slides look good. Everybody still good? It's hard, we don't have an audience. The Medicare Access and Chip Reauthorization Act of 2015 also continued to change how CMS approached quality payment programs. And then ONC at the same time issued to Congress a report on information blocking, which had been based on a lot of the complaints we have been receiving in ONC about the challenges with affordability. And many of those complaints were actually coming from regional information organizations, health information organizations, or HIEs. As you know, HIEs have had many terms and acronyms in the past to stand for the activities that you do. And that really did inform that report. So feedback, I'll say this throughout my presentation today, feedback to the federal government is really important about what's happening in the states and local communities. And that technical assistance provided to Congress really did inform the passage of the 21st Century Cures Act. And in that act, ONC and CMS were charged to implement a majority of the Title IV of that act with respect to health IT. So the 21st Century Cures Act, like high tech and RF shaped the last decade of health IT and interoperability and innovation. The 21st Century Cures Act will continue that innovation and interoperability, and hopefully a lot of additional efforts and energy towards patient access, patient engagement, and consumer choice. So briefly, like the intent of the 21st Century Cures Act was to increase choice and access and quality in healthcare, improve data interoperability, advance precision medicine. A lot of money went to NIH with respect to that. Define information blocking, and this is really a new regulatory construct. And as I mentioned previously, there's probably been nothing like it since HIPAA. Support the states in mitigating opioid abuse, increase access to mental health, and prepare to expand telehealth. And as we know, this was pre-COVID, and there's been a lot of activities with respect to expanding telehealth since the pandemic. So ONC was charged to implement a large portion of the CARES Act, and the ONC final rule, the interoperability information blocking and certification rule. It was finalized in May of last year. There have been a few corrections. Anybody who's written regulations knows that usually happens, especially when your regs are hundreds of pages long. But those were just really administrative corrections. And then there was an interim final rule actually passed last fall in November. And that was really in response to feedback from industry and the challenges with dealing with the pandemic and being health IT developers and providers trying to be supportive of that and not wanting to divert their attention to some of the requirements and the deadlines of the rule. And so the enforcement dates and the compliance dates were pushed back on average 6 months because of the public health emergency. So this regulation from ONC really is for patients, doctors, hospitals, health IT developers, and the American public, really improving interoperability, safety, access to data, protecting intellectual property while also liberating data, maximizing innovation and transparency in healthcare. Some of the notables from the ONC rule are some pretty significant changes to the certification program and also new authorities from Congress to regulate health IT developers, which previously ONC did not have. They just regulated the products that were certified, not the developers and their behaviors. Patient access API, interoperability advancement, and information blocking. This is just a quick slide, and you can go to the ONC Health IT certification webpage, and there's tons of data and specifics about each of the criteria. But there were some criteria that were removed from they're calling it the Cures Plus or 2015 edition, Cures edition of certification. Many of those that were removed were because of the sunset of the Medicaid PI program, such as drug formulary, patient education, secure messaging. Some, like data export, were removed to give time for the requirement of developers to transition over to US CBI. And of course, APIs are a huge component of the data liberation for patients, and so that is a big component of this rule, as well as defining electronic health information export, which for the first 24 months after this rule is limited to the data classes of the US CDI, which I'll talk about in a moment. And after that is really the HIPAA designated record set. So quickly, I'm just going to go over a few of the components of ONC's rule. And so there is an API certification criteria. So that only applies to certified health IT developers. And it's a read-only focus. It's based in FHIR. It's for both single patient and population services. On top of that, one of ONC's new regulatory constructs to regulate developers, as I said, which is new, are conditions and maintenance of certification requirements. And it applies to the actions and the behaviors of certified health IT developers related to their use of certified API technology. And some of the requirements revolve around transparency, such as the data and the documentation to interact with and use the API technology needs to be publicly available. Restrictions and permissions around fees. Fees are permissible, but they need to be charged for the use of the technology, and it needs to be applied uniformly to similarly situated parties. And it needs to be open and pro-competitive. Another big component of the rule is the United States Core Data for Interoperability, USCDI. Health IT developers have to update their certified products to support USCDI for all of the certification criteria that calls out the standard within 24 months. And that was extended because, as I mentioned, because of the pandemic. And so they have until October of 2022. There is a routine annual update to the USCDI. And that is a sub-regulatory kind of ninja-like approach to regulations to address an issue that ONC heard frequently, which is once standards are adopted into the regulations, new standards come out, they're limited by the certification criteria requirements to only those standards that are in the reg. And they felt like innovation was stifled, not being able to go to newer standards. And so something that with the USCDI and something else called the Standards Version Advancement process is going to actually permit certified health IT developers to upgrade their products and certify them to new standards prior to them being adopted in federal regulation. And so this USCDI actually replaces the Common Clinical Data Set next summer. It is content and standard agnostic. Like I said, it has a regulatory update. It does determine what's available for standards version advancement. Some of the data elements within it are expressed in certain standards, such as RxNorm and SNOMED CT, and the elements represent individual concepts and classes like medications, allergies, procedures, care team, etc. So the USCDI was actually version 2. So version 1 was what was adopted in regulation, and so that is what is required. Permissibility to move on to version 2 is occurring, and this was actually approved this summer. And there were 3 new data classes and 22 new data elements added. It will be available for SVAP, so developers can look at this and determine if they want to incorporate any of these new standards. They need to let their certification bodies know that's their intent. They need to incorporate testing of these in their real-world testing, which is one of the other conditions and certifications of maintenance. Maintenance of certification, which is new, is that now developers have to actually test their products in the real world, tell the industry and the public how they are going to test, and then publish the results. And those will all be publicly available on ONC's website. And so version 2 is out, and this is all done through public comment as well. So there's an opportunity for anyone to look at these data elements that make up the USCDI and make a determination if they feel like there are some omissions that need to be added or additional standards that need to be considered. There's a process for all of that. Like I mentioned, I have slides at the back of the deck to kind of go over that for everyone. A notable for version 2 is also addressing health equity and new SDOH related data classes that have been added with respect to goals, assessment, interventions, health concerns, and new data elements for sexual orientation and gender identity. I mentioned the standards version advancement process. At this point in the talk, your eyes are probably glossing over because it is complicated for sure. But the data and information is out there. So I guess the key is to know what to ask and who to ask it of. But if you are a developer and you want to take advantage of the new standards that are now approved through the USCDI process, then you can do so through real world testing through the standards version advancement process. And there is a process to that as well, and it involves working with your certification body, identifying the criteria that are eligible for this, and they are really the criteria with respect to interoperable data exchange and EHI, and indicate that so that everyone knows, including your clients, what your intention is, and then be able to progress through the process of updating your products to reflect these new standards. This is messy, so I can't go through it with you in detail, but it's nice to look at how the USCDI timeline maps up with the SBAP approval timeline. As I mentioned, version 2 of the USCDI was just approved. In January of 2022, it's anticipated that it will be announced that developers can now start testing and certifying to those new standards. And version 3 for the USCDI is now open for public comment. ONC loves acronyms, so the process for that is called On Deck. For baseball fans, that makes sense. So you can go now and into the submission process, which I have a link at the back. You can look at what is being proposed, and you can contribute your comments, suggestions for new data classes and elements to be considered for the next version of the USCDI. I've mentioned a couple of times conditions and maintenance of certification requirements, and this is a new authority that ONC has and the mechanism by which they can regulate health IT developers. They're quite in depth, and there is a fact sheet on ONC's website for each one of these. We briefly talked about application programming interfaces and the real world testing requirements. And I worked heavily on that, and that was from my experience running the certification program for 6 years. The goal is really the transparency for the public, for end users, and for future purchasers of health IT to take a look at the rigor with which health IT developers are testing their products for interoperability and for safety and usability, because those reports are also public, and then their intentions with respect to upgrading to new standards. I briefly want to, well, not briefly, I really want to touch on the information blocking component, because it's kind of twofold. If you're a health IT developer, you have information blocking requirements as a certified health IT developer, and then in general, you have information blocking requirements. So information blocking, I'm sure since this has been out for a bit, everyone's getting up to speed. Unfortunately, we don't have a final rule yet from OIG, so there's still a lot that will be determined going forward in the future to understand how this is going to be enforced and what constitutes information blocking. So the motto really is, it shifts the I may share data that HIPAA has to the I must share data that information blocking requires. So it's defined as a practice that, except as required by law, is likely to interfere with, prevent, or materially discourage access, use, or access, exchange, or use. You'll hear that all the time. Access, exchange, or use of electronic health information, which I previously noted, is defined currently as the concepts within USCDI, not necessarily the standards associated, that is not required, but the data elements represented by the USCDI version 1. And we'll later, next year, go to the HIPAA designated record set. There are actors in this construct, and they're either developers of certified health IT, and if you are a developer of 20 health IT products, but you only have one certified, you're an actor. All of your activities are now under this authority, not just the ones related to the one product you have certified, and that's important to note. And that's a new expansion as well for ONC. If you are a health information exchange or health information network, and those are not proper nouns, they are the activities of exchange, of facilitating the exchange of health information from more than 2 organizations, then you're a health information network or health information exchange. There's a knowledge component. So for the first group, developers, HIEs and HINs, it's that you know or you should know that the practice is likely to lead to information blocking. For healthcare providers, the other actor in this construct, there is a knowledge requirement. It is that they know, not that they should have known, that it was likely to interfere. Cures required HHS to issue regulations on what might be some reasonable and necessary activities that would not constitute information blocking, and those are known as the exceptions. They were intended to be used few and far between. They weren't intended to be a escape hatch at all. So it's important for everyone to consider how their information flows and be cognizant of the now requirement that you must share, and determine if there are ever cases in which you wouldn't share, and work with your compliance offices, your health IT privacy officers, to really ensure that you've documented well what those situations may be and how you would address those in a uniform manner across all similarly situated entities. Also, HHS directed, or the Cures Act directed HHS to set maximum penalties for violations of information blocking, and that will be done in collaboration between ONC and the Office of the Inspector General. So ONC receives all of the complaints of information blocking, and they triage them, they assess whether they are related to certified health IT, and if so, that's dealt with through the ONC program and the certification bodies. And as well, it's shared with the Office of the Inspector General, who is in the process of rulemaking to define how they will implement their new authorities with respect to civil monetary penalties for information blockers. Nature and harm of the information blocking, the number of lives affected will all be factored into this final rule, which I think is expected this fall, which can be the end of December in the government. And appropriate disincentives for providers and the penalties for providers will be determined by CMS, and that is yet to be determined. And also required, as I noted, an information blocking complaint mechanism and reporting. ONC has established that. It was actually established prior to the rule. So ONC has a health IT feedback form where you can submit complaints about safety concerns, privacy and security concerns, interoperability or lack thereof of your health IT, and your any concerns about information blocking. I'm doing a time check, and I have a lot of slides, so I might move real quick through some of these, but I did briefly mention who the actors are. The enforcement date for information blocking has already begun, so they are still collecting all this information. We are awaiting the final rule from OIG. And again, the actor must respond to the request for EHI, and it's currently limited to USDBI and will expand in October of 2022 to the HIPAA designated record set. The rule, both the Cures Act and ONC's final rule had numerous examples of what might be considered information blocking. As you are probably familiar with other activities of HHS and OIG, we might not know it till we see it, right? And so you should just always share information. That's the best way to go about it. But here are some examples of what would be likely considered information blocking. I won't read them all to you, but it surrounds improperly citing HIPAA, fees that make it cost prohibitive to share, limiting healthcare providers or vendors from sharing with other health IT systems and locking them into a certain system, making it difficult to transition between certified information technologies. So those are all some examples of what would be considered information blocking. I noted that there are exceptions to information blocking. These are the 8 exceptions. Some of them involve reasons to not fulfill or exchange EHI, and some of them are exceptions to the manner and the fees associated with fulfilling the request. There are fact sheets on each one of these. And the intent really is document, document, document. Ensure you are taking a good and hard look at your information sharing policies to ensure you are not information blocking. And if you think you are, or there are reasons that you should, it is time to really put pen to paper and pull a group together to start to document those in a way that would protect you against any claims of information blocking, but with the caveat that these were intended to be few and far between. We'll move on to TEFCA, the Trusted Exchange Framework and Common Agreement. I'm sure you guys have heard about this. It's been lingering for a long time, and folks expected this to actually be required in both the ONC rule and the CMS rule, but we're not quite there yet. But the QHIN technical framework is actually out now for public comment. So I encourage you to go to the Sequoia Project and take a look at that and contribute your expertise and voice your opinions on that. I've posted their recently released timeline to finalizing the TEFCA. And the intent of the TEFCA really is just to develop a support a trusted exchange framework for interoperability and a common method for doing so, rules for exchange, and a process for adjudicating non-compliance. This is just a nice graphic that shows how the recognized coordinating entity would interact with the QHINs and then the participants of the QHIN with the goal of trust and a trust infrastructure for networks to exchange with other qualified health information networks. So just a policy comparison. I think it's just a good graphic to note that, you know, what HIPAA allows you to share and TEFCA highly encourages you to share. Info blocking requires that you share, that you must share. As we await the HIPAA final rule, because there is a final rule for proposed modifications, it will be interesting to see how it incorporates the new info blocking rules and patient access rules from CMS and the components of TEFCA. Timelines are always good, especially when there's so much going on. I've placed the slide in here. It's the most recent one from ONC that incorporates their interim final rule that had the permissibility for delay of enforcement dates because of the pandemic. And so key here is the change from USCDI to and the restriction of the limit currently placed on EHI that will take place next fall. The real world test plans from developers will be due here soon in December. So I would keep this just handy and so you can stay abreast of what's coming down the pike and opportunities to engage. So I know there's a lot in the room who are experts in CMS, and you have your RECs in the room, and they know CMS payment policy and CMS rules, especially with respect to Medicaid, way better than I will. But there is a companion rule to ONC's rule, and that usually does happen where ONC and CMS, the rules related to health IT and use of health IT come out as companion rules. So they're very complementary. The CMS rule was the interoperability and patient access rule. And the high points from that is the ADT requirement as a condition of participation, which is now effective. And I'm sure you guys are all dealing with that. And then the payers must adopt FHIR-based API to share data with their patients. And the goal was always the patient could have their data on their phone when and where they need it. And later or early next year, the requirement for payers to share data with other payers. So patients can move from payer to payer and have that data go with them as well, not just at the provider level, but at the payer level. CMS has shared the slide. It's important to note that the dates on here are usually the effective dates, but not necessarily the enforcement dates. I think many of you are familiar with these and many have passed. The most recent that just came online for enforcement dates are the Patient Access API and Provider Directory API that I just mentioned, as well as the ADT notifications. So forthcoming is the payer-to-payer data exchange and the improved coordination of benefits, and that's all next year for all of the components of CMS's CARES Act rule to become finalized and implemented. I think many in the room are familiar with this, so I think it's a good slide for reference, but I think it's also important to note that this ADT requirement for Medicaid and Medicare and Medicaid participating hospitals are for all patients, not just Medicaid patients, for that data to be liberated and sent for care coordination and quality management activities. And it's for all ADT events. There are not standards required, so it's really, just name of the treating provider, name of the patient, and the institution. It is important to also note that CMS explicitly outlines that the hospitals can use an intermediary such as HIEs to meet these COP requirements. And I know that many are doing that. Consideration of time, I just wanted to know that both the STARC and the anti-kickback regulations were recently updated, reflective of cures. These are highlights of those. I have links to the final rule there. It was really that HHS expected the modifications would encourage the development of value-based arrangements while minimizing the potential for fraud and abuse. And if you've watched the news, there's been quite a bit of fraud and abuse with respect to use of electronic health records and reporting of meaningful use to Medicare and Medicaid. And then the Stark Harbor revisions also eliminates that sunset, this is important, eliminates that sunset provision, which would have only protected EHR donations through December of this year. It deletes the prohibition on the donation of EHR replacement technology as well. So CARES talked a lot about telehealth, and this was all pre-COVID, but they did acknowledge the need for improved telehealth as far as the hardware and the connections, as well as laws to permit telehealth in situations where it previously hasn't been permitted, and changes to payment requirements. So we know during telehealth that there was a temporary enforcement discretion that HHS released that permitted telehealth to be conducted pretty much with any application, whether it's HIPAA compliant or not, as long as it's not public facing. And I think all of us have probably had the experience of benefiting from this new lapse in the regulatory enforcement and their enforcement discretion to permit these new policy changes, but they have not been finalized as of yet. These are just as another slide just to discuss the actions HHS has taken during COVID-19. And I know you have a telehealth session later on today, and I don't want to steal their thunder, but just keep this slide in your pocket to kind of understand some of the permissions that were waived or new permissions granted to conduct telehealth during COVID. So Congress has been really active in this space as well. 150 telehealth bills have been introduced. Unfortunately, all but one are stalled. It's important to note that the American Rescue Plan Act of 2021 also has infused a lot of activity and authorities and appropriations in the areas of both telehealth and social determinants of health. And again, social determinants of health, near and dear to my heart. I led ONC's portfolio on SDOH right prior to my retirement last November. There are several components in the American Rescue Plan for that, as well as numerous bills that have been introduced, as well as a lot of novel things that the federal agencies are doing at CMS, at CDC, and ONC with respect to supporting programs and issuing grants with respect to supporting and better understanding social determinants of health, especially critical during this pandemic as COVID-19 has definitely illuminated more of the disparities and vulnerabilities and health equity concerns in the country. I guess the other thing I'd really like to note here is that HIEs and Kentucky as well have been really working closely with public health agencies and community agencies to support the COVID response and address these new use cases. Despite the very significant policy and governance work, including interacting with non-covered entities or those without business associates agreements. So, you know, it's not inside the Beltway where a lot of these changes happen, right? It's in your communities, and you know, I'm really proud to see the work that Kentucky has done in this space and will continue to do. Just, you guys probably all know this already, but the General Assembly adopted resolutions to address social determinants of health with respect to addiction recovery. So yay, Kentucky. As a nurse and also as a CASA court-appointed special advocate volunteer, I'm well aware of the impact of, I think, an unfortunate nature that substance use disorder has on individuals, on their families, on their communities. So it's nice to see that that's being addressed at the General Assembly level within Kentucky. And of course, CURES Act appropriated $1 billion to states for substance use disorder mitigation programs. So that's the end of my formal speech, my formal talk. I wish we were there interactive to have this conversation. I will be around in the later session today to ask any questions. On my next slide, I have my contact information. But I just wanted to kind of hit it home as I was reflecting on this talk today and my experiences throughout my career in the military. You know, I've had the privilege of working on the USNS Comfort, which is the nation's largest, most, you know, it's a full hospital. You probably heard about it during the its sister ship, the Mercy, during the COVID response. I was a nurse at the President's Hospital at Walter Reed National Military Medical Center, at the National Institutes of Health Clinical Center. Got to be on the forefront of the establishment of the federal program ONC, who's charged with the nationwide health information network. And so as a new informaticist, that was like a very meaningful experience for me. But I would have to say, through all my years, being present 16 years ago when Hurricane Katrina hit was transformational for my personal life and for my professional life. And it's my why. It's why I continue to stay engaged in health IT and why I'm passionate about health IT. This is a picture of the Pete Maravich Stadium at LSU, where we triaged 16,000 patients that were being evacuated from New Orleans and the surrounding areas that were hit by Hurricane Katrina. Flew out in helicopters and grabbed people and brought them back here. They came on buses and they walked in the doors, and 16,000 patients in 9 days were triaged. And what struck me as a just recent grad of my master's in informatics and having had the experience to work at some of the top-notch places in the country and have always used electronic health records is the lack of data that we had when we met these people in crisis, in need, in a crisis situation. They didn't know their medical information. They didn't have it on their smartphone. They didn't have their medical records. If they could not speak to us or were too injured, we had no information on them at all, no next of kin information. So operating blindly like that in such an austere situation, in a crisis situation, is not optimal for anyone, for the patients and for the providers. And that experience for me really hit home. What would it have been like? And there was actually an after action report sent to Congress if we had had information, if we had had data interoperability, if our patients had had information on their smartphones, or a family member had that information, how would their care have been improved in this situation? So it's not a pandemic, but it was a crisis, and disasters and pandemics are going to continue to challenge us. And we're going to have to rise and grow while we abruptly face these challenges. And in them, we'll learn and we'll understand what our blind spots are and what our deficiencies are, which will then inspire us to do better. So Hurricane Katrina was that for me. And although it's 16 years later, I know we've come far, but I feel like we have far to go. I think COVID-19 has shown us that, but I think we're all capable, and we're here meeting today to talk about how the work we do can improve the care of individuals, both in standard healthcare settings and in crisis settings. So I'm excited to be here in Kentucky and to do this work with you all. It's my contact information and some resources to engage with the hyperlinks with respect to really contributing to future policy that you will have to implement and that will impact you.
Okay, well, thank you everyone for attending the session today. Our next session will be our C-suite panel, and we hope to see you over there. Like Dr. Farlisi said earlier, she'll be on one of the networking events later on. She can answer any questions you may have, but if you want to go ahead and start filtering on over to the next session, we will start shortly. Thank you.